Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, Pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. We've got that free 31-page PDF on the top 200 drugs. Great little study guide, great refresher on some of the most important things that you're going to see out in practice, as well as in your board exams and pharmacology learning career. The medications I want to cover today are Sevelamer, Dalteparin, Sertraline, Clonazepam, as well as Irbesartan. So got a little bit of variety here. Let's get started with Sevelamer. Brand name of this medication is Renvela. This is what's classified as a phosphate binder, and its primary use is to manage elevated phosphate levels in patients with chronic kidney disease. So hyperphosphatemia, elevations in phosphorus levels, are a significant problem, particularly in later stages of CKD. And this medication is ultimately going to help to do that. It does it by binding phosphorus in the gut and preventing systemic absorption. So you get phosphorus from your meals, from your food. So as you would expect, if we're trying to bind that phosphorus in the gut, we've got to give this medication with food or when patients are eating. So that's definitely a really, really important thing to remember with that administration of this medication. It does need to be dosed like that. So where we can run into issues, and what I've seen in practice, is if we do have some drug interactions or some other medications that we need or want to take with food, and we're on a phosphate binder and we have an interaction there, that can be an issue. So, and I'll talk a little bit about that in drug interactions as well here. Sevelamer is a non-calcium based phosphate binder. So elevations in calcium can be a problem in CKD as well, hyperkalemia. If calcium's not an issue, it's not elevated or it's low, we typically are going to use calcium-based phosphate binders. Like Phoslow is a good brand name example there. I believe I've covered that in the past plenty of times. So go check that out if you're interested in that. But anyway, Sevelamer avoids adding to that hyperkalemia problem. So that's really one of the primary uses for this agent, is when we've got those elevated phosphate levels also associated with elevated calcium levels. Adverse effect profile, it's going to be primarily GI adverse effects. Diarrhea can certainly happen, stomach upset, abdominal pain, nausea, even vomiting if it's severe enough. That can, risk can go up as we increase the dose, again, kind of based upon those phosphorus levels. From a monitoring parameter, it's probably what you would expect. We're going to monitor phosphorus levels. Obviously, that's what our goal is. That's what we're trying to treat. Calcium levels. We're also likely going to monitor parathyroid hormone as well, which is kind of within that cascade, if you will, of regulatory control. Normal calcium levels range from 8.6 to 10.2 milligrams per deciliter. Again, this can vary based upon the lab, but again, we're going to do that in the monitoring with this medication. Phosphorus levels and in CKD in general, I should say. And then phosphorus levels, typical normal range, 3 to 4.5 milligrams per deciliter. Again, can vary a little bit based upon lab. But again, we're going to kind of track that, monitor that, make sure we're bringing that down to a more desired level. From a drug interaction standpoint, I alluded to it before, but we can have some binding interactions. Wanted to mention there are some drug-food type interactions, so this is good for dietitians to know sometimes. As a reminder, I got a book on Amazon on drug-food interactions from MedEd 101. If you just search that, you'll be able to find it. Anyway, this medication can potentially reduce vitamin D, folic acid, vitamin K as well. So those are some of the, I think, the most important ones. So it's important that, you may need to supplement with these patients, or at least monitor and assess those levels, particularly folic acid and vitamin D. Vitamin K, obviously, that could be a challenging interplay if you've got a patient on warfarin, for example. So, really pay attention to that, watch that closely, monitor INR. That can be a potential issue there, depending upon the absorption of vitamin K, and if that varies a little bit when we start or increase this medication. And then binding interactions, probably the most prominent interaction to be concerned about, ciprofloxacin, levothyroxine. These are two kind of classic examples. So we always try to separate if possible, 2 hours before or 6 hours after. With something like levothyroxine, we're probably going to obviously be monitoring TSH and thyroid function levels. So that's something to kind of watch over time there a little bit. All right, next medication, we got Dalteparin. Brand name is Fragmin. This is a low molecular weight heparin. Mechanistically, it is a anti-factor 10A, and that's more so than 2A, if you remember the clotting cascade. So that's its primary mechanism, is that anti-clotting factor 10A. Kind of blocks that, reduces that action. So when we use an anticoagulant, obviously we're thinning the blood. Primary indication that I see it used for is DVT prophylaxis and treatment. Typically in treatment, and that's probably true of just about any disease state, in treatment of any disease state, typically we're going to use higher dosages than in prophylaxis, which is true of this medication and kind of its cousin, enoxaparin, as well. Bleed risk is obviously the biggest thing with this agent, and I'll talk about drug interactions coming up here. It's a high alert medication on ISMP's kind of safety list there. Other than that kind of blood loss, bleeding risk, thrombocytopenia, specifically heparin-induced thrombocytopenia, is a possibility with this medication because it is within that similar class. So from a monitoring standpoint, obviously we're going to be checking, hemoglobin, kind of CBC in general, but we're also going to look at those platelets as well and make sure that we're not causing heparin-induced thrombocytopenia. All right, from a drug interaction standpoint, anything that increases the risk for bleeding, you got your antiplatelet medications, other anticoagulants, that's going to present a risk, obviously, to the patient to increase bleeding. Some others that are kind of a little more less well-known, if you will, I guess. NSAIDs, I guess, pretty more common that way, but GI bleed risk there is definitely a no-brainer when we use an anticoagulant like Dalteparin. Adding an NSAID on top of that is going to increase that risk for GI bleeding. SSRIs, SNRIs may have some, anti-platelet bleed risk type activity. Typically not crazy high on my list. I don't worry about it as much as, let's say ibuprofen, for example. But there is that theoretical risk and some evidence to indicate that there may be an issue there as well. Rarely, you may see some elevations in potassium. Again, I'm not typically worried about it unless I've got maybe an at-risk patient already for hyperkalemia. Maybe their, renal function isn't that great. Maybe they're already on an ACE inhibitor. Maybe they're on a potassium-sparing diuretic. Adding Dalteparin to that may increase that risk for hyperkalemia a little bit more. All right, moving on, we've got number 148. This is Sertraline. Brand name is Zoloft. This is an SSRI as its classification. It inhibits serotonin reuptake in the central nervous system, so ultimately increases serotonin in the synapse, and that ultimately helps improve mood, depression. Also has been shown to be helpful in anxiety-type situations, panic disorder. There's numerous psychiatric indications that this medication can be used for. All right, so one of the most important education points with this medication, particularly for patients, it does take a little while to work. May take up to a few weeks to even begin working. And so that can be a challenge for patients. If they take a couple days worth, they're like, hey, I don't feel any better. Definitely need to educate them. It takes a little bit for this medication to start working compared to the side effects, which will definitely show up right away in most situations. With specific SSRIs, selecting sertraline versus another agent typically depends upon kind of the adverse effect profile, provider preference. You may look at drug interactions. Is it, better in the elderly, for example? So there's a few different things that we kind of look at there. With sertraline, it does tend to have a higher incidence of diarrhea. So if you've got a patient that's more predisposed to diarrhea, we're probably going to, lean towards not using sertraline in that situation. Other things to consider and think about, sertraline does have a little bit better evidence, safety evidence, in patients who are pregnant. So that's maybe a situation where you'd be a little bit more likely to use, sertraline compared to, let's say, paroxetine in pregnancy, which does not have a great safety record there. Other kind of generalized adverse effects of SSRIs in general. So pay attention to any CNS changes, dizziness, worsening confusion, changes in sleep pattern. These are all things that can happen, not incredibly common, but certainly any type of central nervous system changes you should pay attention to. Sexual dysfunction is a risk with SSRIs, as well as serotonin syndrome, of course. Last, I did want to mention hyponatremia, risk for syndrome of inappropriate antidiuretic hormone. So, drops in sodium can happen. Most clinicians will, worry about it. Obviously, if a patient presents symptomatically where there's, central nervous system changes and their sodium's low, that's a problem. Most clinicians probably won't worry about it too much as long as sodium levels are in the 130s, for example. Typical normal sodium level is 135 to 145. If you start getting into the 120s, that's definitely a lot more concerning. But again, can vary based upon past history. Is that level stable, and all that sort of stuff. Additionally, if you've got patients on other medications that can lower sodium levels, like diuretics, that's something to be aware of as well in kind of tracking and monitoring for that risk. There is discontinuation syndrome as well with SSRIs like sertraline. You can have some GI upset, some insomnia, some anxiety, flu-like symptoms if patients abruptly discontinue their medication. Typically, on the medication for a longer period of time, higher dosages, that's going to increase that risk, of course. All right, from a drug interaction standpoint, I think about MAOIs as well as other serotonergic type agents. This can increase the risk for serotonin syndrome. And then other interaction, I kind of think about is, blood thinners. There's that theoretical risk that it may increase the risk for bleeding, and maybe some evidence to show that it does do that. Patient taking, baby aspirin and a low dose of sertraline, probably not something I'm terribly worried about. But again, something we can pretty easily monitor with, bruising. Are they frequently having, bleeds or nosebleeds or something like that? We can easily kind of keep tabs on that and track it that way. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, NAPLEX, geriatrics, BCMTMS, go check out meded101.com/store. We've got tons of testimonials over the years of people we've helped pass their board exam. We're really proud of that, and we think we can help you too. So again, go check out all those links, meded101.com/store. All right, moving on, we've got number 149, which is clonazepam. Brand name is Klonopin. This potentiates the effect of the inhibitory neurotransmitter GABA in the central nervous system. So kind of settles down the nervous system, if you will. It's going to cause, some sedation. It can potentially relieve anxiety, which is, probably one of the more commonly used indications there. With this, it is a Schedule IV controlled substance. So, ideally we want to use this medication for a short period of time. Those adverse effects I alluded to, sedation, I equate the benzodiazepines like clonazepam to alcohol in a pill. I think that's a pretty good analogy for the most part. Slurred speech, confusion, fall risk, these are all associations with the adverse effect profile of clonazepam. Flumazenil is sometimes a commonly asked question on pharmacology and board exams. This is a potential reversal agent for benzodiazepine overdose or toxicity. Note that it does carry a boxed warning for seizure risk. So there's plenty of potential concerns with using it, but I have seen that come up on board exams and things. Clonazepam is what's called an intermediate-acting benzodiazepine. An example of a short-acting one is triazolam. Intermediate are alprazolam and lorazepam and clonazepam. So those are probably some of the more commonly used benzodiazepines. Longer-acting benzodiazepam is probably the most commonly one used there. From a drug interaction standpoint, I think about the warning with opioids, increased risk for respiratory depression and sedation. And then the other thing I worry about, particularly with clonazepam, are excessive sedative type medications. You could have some of your older skeletal muscle relaxants. You can have, sleepers like, trazodone, maybe mirtazapine. You can have antihistamines, older antihistamines such as, diphenhydramine, for example. These can all have kind of additive sedative type properties and potentially zonk out your patient, obviously increase their risk for, sedation into the next day, potentially increase that fall risk, those type of things, as well as, driving, operating machinery, that type of thing. Clonazepam can certainly add to that risk when used in combination with other. You can do it by itself, but when used in combination with other sedative type medications, can kind of have that doubling of effect there. All right, last medication, number 150, is Irbesartan. Brand name is Avapro. Also comes in a combination Avalide, which is a combination with hydrochlorothiazide. Naturally, this is going to be used to manage hypertension, as it is an angiotensin receptor blocker. So mechanistically, by blocking angiotensin receptors, we ultimately prevent the binding of angiotensin II. Angiotensin II is a potent vasoconstrictor. So again, by blocking the action of angiotensin II, we're going to cause some vasodilation, potentially lower blood pressures, which is what we're trying to do here. With ARBs in general, if you know ACE inhibitor adverse effect profile and issues well, you're going to be able to know some of the concerns with ARBs as well. So think about ACE inhibitors without the cough as far as the adverse effect profile. So elevations in potassium can happen. Angioedema is a rare but potentially very serious adverse effect. You can get swelling of the lips, the mouth, and into the throat, which can, if severe enough, can block off breathing. Need to pay attention to renal function as well as potassium when we're doing our monitoring there. We can have an increased risk for acute renal failure, probably more likely if you got patients on NSAIDs and diuretics. But typically we monitor that creatinine. If you see that creatinine jump, greater than 30% is typically kind of the guideline there. So if you get a patient's creatinine jumping from 1 to 2, like obviously that's a situation where we're really concerned. Like, okay, did this recent medication, contribute or add to an acute renal failure type situation? So again, you're going to want to keep tabs on that as well as potassium levels. Avoid ARBs like Irbesartan in pregnancy. This is true for ACE inhibitors as well. They can definitely cause some issues with that and should be avoided. All blood pressure medications can add to orthostasis, so that's a potential drug interaction concern there. And then the potassium raising medications, I think of spironolactone, for example. Trimethoprim is an antibiotic type medication that can raise potassium levels. So the additive effects of hyperkalemia, additive effects of hypotension if you got a fall risk patient, those are kind of the drug interaction profile that I look at there. And then, of course, ACEs and ARBs work on the same pathway. They should absolutely be avoided using them together. All right, well, I think that's going to wrap up the podcast for today. Thank you so much for listening. If you enjoyed this, please leave a rating review on iTunes or wherever you're listening. Share us with friends, colleagues, pharmacy students, nursing students, med students, anyone who could benefit from some pharmacology education. I greatly appreciate that. If you have any comments, suggestions, feel free to reach out to me at mededucation101@gmail.com. You can also connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. With that, I'm going to sign off for today. Thank you so much for all the support. I hope you have a great rest of your day.